If you've been practicing for about 10 years or more, you're likely seeing some newer conditions, at least conditions that weren't previously diagnosed, entering your clinic doors. Ehlers-danlos, POTS, and mast cell activation syndrome can occur together and are more commonly walking through clinic doors looking for your help. This week we have Abby Gordon, a physical therapist at Seattle Children's Hospital, in to share her expertise in helping people dealing with these conditions. We speak to common patterns we see, the role of lifestyle medicine, working with parents of kiddos with these disorders, and more. This is a great conversation that I think you will get some significant value of as these conditions walk through your clinic door. Enjoy.
This is the Modern Pain Podcast with Mark Cardula. Welcome to the podcast, Abby.
Thanks for having me, Mark.
You know, we've chatted a bit before, and I've definitely followed you a bit online. What spurred our discussion today is two clinicians who are kind of on the front lines of trying to deal with some conditions that are, still kind of new, and we'll talk about those today, of course. But Abby has some great content. We'll link her Twitter follow. She's always got some good commentary and things on Twitter X, whatever the heck we're calling it these days. Abby, if you don't mind, I know about your background and things, but maybe the audience doesn't. If you don't mind introducing yourself a little bit and kind of your background.
Sure. Hello, everyone. Abby Gordon. I'm a sports physical therapist at Seattle Children's Hospital. I'm about to have been there for 7 years. And I'm also about to hit 10 years as a physical therapist. So I feel like I'm hitting some nice landmarks in my career. I was the team physical therapist for the Seattle Storm WNBA basketball team for 8 years. So I did a lot of work sports related, specific to women's sports. But in the clinic, I started to gain a lot of interest around chronic pain. And so I'm part of the pain management clinic at Seattle Children's. And I basically just treat kids between ages 5 and 21 for musculoskeletal injuries, sports related injuries, or chronic pain. So it's kind of where I'm at.
And that's interesting. I like it because it's kind of the similar spread. I mean, I see everything from the pediatric athlete to the geriatric chronic pain, debilitated, and everything in between. So it's fun to have that spread. I mean, nothing wrong with niching down and really focusing on one thing, but I'm definitely similar where I like to see the gamut of things. And then still, obviously, the chronic pain. That's obviously how our discussions happen. Is we both like to nerd out and chat about chronic pain. So it's obviously a fun topic to talk about in our eyes. What we wanted to talk about today, because I had reached out, and Todd Davenport, so hopefully we're going to get him on the podcast too, just to talk about some of the new conditions, as far as being more recognized and more something that we're seeing come through our clinic door. And one being Ehlers-Danlos disease. What's been your experience at Seattle Children's with that? I mean, in your 10 years, you're hit the decade mark right now. What's been your experience with that diagnosis as far as the prevalence of it in your practice? Have you seen that kind of uptick that it seems to be folks are seeing around the country, world for that matter?
Yeah, I've seen a pretty good handful of teenagers who've had Ehlers-Danlos. Almost all of them female, but not all, which has been interesting because the females have not presented the same as the male did. But I've seen them for two kind of different clusters of things. So one cluster has been like joint dislocations where they ended up having surgery at several shoulder dislocations and a lot of the knee, where we see the MPFL surgery that I feel like if you're in adult orthopedics, you see so much about ACLs, but when you do peds, you have like the ACL group and the MPFL group, which is the medial patellofemoral ligament. And when you dislocate your patella, that's part of like the retinacular structures. And so they kind of like reconstruct that to keep your patella in place. So I see a lot of those, and the rehab is kind of similar to ACLs. The protocols are a little different, but I see that as like one cluster for these kids where they've had like a really big injury, but they're playing sports, they're active, and they don't really have a lot of other things going on. And then there's this other group, which is usually coming from our chronic pain clinic, where they have like systemic everything. They have fatigue, they have dysautonomia, potentially POTS. They might have like, I usually share these patients with our occupational therapists because they often have a lot of hand related issues. There's assistive devices involved. And as the sports PT in the team, I don't usually do a lot of work with our assistive device ordering and with orthotics and prosthetics. And so we kind of They end up being more of like a team approach patient who sees a lot more medical, where there's medications on board, probably cardiology is on board, neurology. Like they're very different ends of the spectrum considering they're the same diagnosis. But like, we have gymnasts who are super flexible who have an injury, and it comes to find out that they also have the diagnosis, or you have kind of the opposite end of the spectrum.
Yeah, it seems there's probably a lot of folks operating in the world with that diagnosis before it was even recognized as a diagnosis. Just they were, loose jointed, double jointed, all the things that we used to say. I have friends and folks that you come across in the past who always could do those like party trick things with shoulders and things. And oftentimes the EDS folks are folks. Yeah, I can do all these different things. Well, let's pump the brakes on exposing that too much. I'd love to, we're going to come back to the first group because I definitely work with some of those folks as well, where they're athletic, they're kind of actively engaged in sport and activity and obviously injuries and things where there's not as much of that passive support, where things can get strained, injured, and so on. The group with the more systemic dysregulation, I'm curious what you've seen. I've seen definitely some of that. I'm working with somebody right now. I only saw for the first appointment and really just sat and talked and laid out a plan of what we would look to do. And younger person who's really, and sad to see, because I know you've seen some tough stories your way too, where, functioning, kids, which, they should be enjoying school and doing all the things kids should be doing. And they get these illnesses that, flip their world upside down, not able to function, not able to get to school, not able to do the things that, everybody in their age group's doing. I'm wondering what you've seen as far as, and maybe what you do at CL Children's in your group, because I know it's obviously a team approach. Have you seen any like adverse childhood events type things or like kind of trauma backgrounds with some of these folks? I know it's definitely been something that has been not all, but a pretty sizable percentage of folks that I've seen who have this systemic dysregulation. When you start gaining a therapeutic alliance and discussing all the things that can influence systemic dysregulation, we talk about trauma and things. I'm curious what your view has been and what you've seen.
Well, I think first and foremost, like ehlers-danlos is not one thing. It's a list of different genetic possibilities. So we potentially need to recognize that there are diagnostic criteria. It's almost always genetic studies, but that the hypermobility type doesn't really have a specific genetic finding. So a lot of the times these kids come in and they're like, their diagnosis is just hypermobility, and all you have is a Baton score 9 out of 9. And then it's like, take them in PT and help them. But what they really have is hypermobility with GI dysfunction, usually some sort of like allergies, like something immune related, where either like food allergies or medication allergies, or they have Crohn's or celiacs, and like those are such different things in and of themselves. And so there's like those things which come with medications. And then we have a lot of the time, like a brain fog type descriptor of either like a lot of fatigue or just energy challenge, difficulty tolerating activity, even at like baseline. And then potentially even more than that. So, and also I would say, I don't know the number from the literature, but I would bet that it's probably something like 20% are on the autism spectrum or have some sort of sensory differences than what we would consider typical if you're just in a regular clinic versus where I get like these really interesting specialized cases. So not that you would change your clinical treatment pathway for someone with autism, but if they're really sensory sensitive, most of them are wearing noise canceling headphones for our PT sessions. And they're like reading my lips for me to tell them what I want to do. Or we're in a treatment room, so they're not in the busy gym space where there's weights and other kids and families and music playing. Sometimes we dim the lights. Like there's a lot of sensitivity in general when they have this more complex pattern. And then on top of that is the dysautonomia and the POTS, which is something that I think I've been reading a lot more about and talking a lot more about, and also talking with Dr. Davenport about with the fatigue and just like the clusters that I was finding. He's been like an incredible mentor to help with a lot of these patients that I'm very fortunate that we're in the same time zone.
Yeah, no, there's always good that you have somebody you can text or message or something to bounce ideas off of. I know Todd, Dr. Davenport's doing some great stuff as far as leading the way and doing a lot of things within some groups to help these folks that are dealing with, some of these challenges to get better understood, better listened to, and hopefully better helped overall.
Specifically for him, I think we talk a lot about the differences between when you get a patient. Like I get my patients a lot of the time from the pain clinic. And so our approach with a lot of kids with pain is to get them moving because they're fearful of movement because of the pain. But a lot of the time with the kids, like with Ehlers-Danlos or also with long COVID, there's a fatigue component that I think gets missed because they're not complaining about the fatigue. They complain about pain. It hurts, it hurts, it hurts. So I stay in bed, and they're not really like focused on that fatigue. But then when we start getting them moving, the fatigue worries me a lot more because of the crashes that come when we start the exercise.
Yeah, sometimes you find out the hard way that they're very exercise intolerant and the post-exercise malaise. And I know there's another term
myalgic encephalomyelitis.
Yes, exactly. Chronic fatigue syndrome and those type of things I get. Yeah, it is definitely had folks where you think you're starting at a low level and you think you're really but they're just so reactive, and that fatigue response is just extreme. So you can understand why people who deal with that are a little bit hesitant to engage in exercise and want to get after that. And that's where really having a good ability to sit down and discuss with somebody, the approach and starting very small and making sure they know and bringing those emotions out into the room. What's been your strategy? Like, do you feel like there's some things you found more helpful to like just sit down and level with somebody and really validate where they're at and validate their fear to engage with you as a physical therapist? I found that to be helpful, just so they know, hey, I get that you're afraid to engage and you don't want to have that fatigue response. You don't want, your heart rate to spike to, and have these syncopal episodes and all these different things. What's been your experience with just kind of that being a good human component of care?
I mean, one big key experience is that a lot of these kids haven't had physical therapy ever before. So potentially I'm the first one they're meeting. And sometimes when I say this, it either sounds cocky or just a little bit extreme. Like, I don't think I'm the same as every other physical therapist. That's not to say better or worse. It's just that I'm willing to sit for a whole session and never make the patient move if that's the best thing for our therapeutic alliance and for their recovery. And that doesn't scare me, where I think it probably would have 8 years ago at the beginning of my career, where it was like, get your 4 units, bill, make sure you've touched them, make sure, ice has been on them, and then send them on their way when I work somewhere else. My career has evolved, and now, I still bill for a session, but sometimes the session is us sitting and talking and coming up with a plan. And sometimes it's 3 or 4 and we try breathing strategies or education, but they don't know about vital signs. They only are worried about the pain, and they've been told that this is the problem. So I don't want to just come at them with you're wrong. They're children and their families are scared. So I have been trying to get the hashtag Team Therapeutic Alliance to trend, but someday.
Hey, we'll push it. We will get that nudged forward, hopefully through the podcast a little bit. But I am fully on board. I love what you talk about as far as spending an hour. I used to, again, I'm blessed. It sounds like you're blessed as well to work in this scenario where there's not this productivity pressure. I mean, obviously we can't just sit there and sip coffee and eat donuts with patients and not do anything productive. But I think some of the most productive things are sitting down in front of somebody and validating what they're going through, listening to their story, putting everything that they're talking about on the table, and making a plan up, and starting with some basic breathing things and different things.
Insurance has the biggest problem with this. They start denying it, saying you didn't do any movement and you don't have, a measurement of strength. And I'm like, kid can't get out of bed. What more do you need?
Yeah. And that's where I've because we've obviously have students come through our clinic at Midwestern where I do, clinical mentoring and stuff. And sometimes functional, just like you do in the acute care hospital, bed mobility and what kind of vital responses they have. And like, you can talk about some of the basic things like patient unable to sit upright without, significant, distress or whatever it may be for that patient, where you can kind of bring it down to kind of just more basic mobility skills. And then, maybe some basic movement screening stuff. Just, I've actually had some patients say, hey, we're going to make the insurance company happy. And we're going to just have you do a few movements, safe movements that you can do. You're not here to push through anything today. So just let's see what you feel comfortable moving like. And, obviously make sure they're feeling like they're safe to do whatever we ask them to do. But yeah, it is so frustrating, the insurance company. And because I can understand the thought of what they're trying to do as far as have some quality control and make sure the money they're reimbursing us is going to good care, but they just have this like algorithmic, and I can obviously go into some tangents of how they take research and means statistics of group averages, which none of these folks are the average patient. They are dealing with some very challenging things that don't fit current. I mean, obviously we're going to do research and group research on groups of folks with this, but yeah, it is so frustrating when insurance companies are driving so much of the care, which it should be what's best for the patient, of course, but maybe too much of a utopian view, unfortunately. But I'm curious, kind of backing up a little bit, because you talked about some of the myriad of conditions that a lot of these folks, the GI contributions, dysautonomia, all these different things. I'm wondering at Seattle Children's, or maybe you do it yourself, do you have like any specific educational things, maybe approaches you do, or maybe within your system to help people connect the dots to it? Because I've just found, and I'd be curious what your experience is as well, is like a lot of times they get to like the forest of trees of every ologist out there who's got this is your GI tree, and this is your, cardiology tree. And there's all these ologists who focus on one tree in a very complex forest. This is pretty much my shtick to the patients that I talk about. Like, we're going to talk about how this stuff all kind of relates, of why the cardiologist needs to see you, why the GI, why you're sensitive to smells and foods and, all these different things. What's been your experience with that as far as people putting things together for patients?
Yeah, I mean, the biggest thing for me is that I know how lucky I am that I'm in a hospital system. So like, I'm in an outpatient clinic, but I have directly across the hall orthopedics, cardiology. I have an eye doctor across the hall. Like, I'm in a space with a speech therapist, occupational therapist, a PT who does rehab, congenital PT. So I don't have to ever do those things. And I only do sports, and they don't ever want to see an ACL. So there's 75 specialties that come through my building in a week. That's not what everyone has. I can't even list them all, but I know that if a patient that I'm seeing has something strange, someone in the building is going to be able to help me figure out where they need to go. And I know that is not what most people have, but I also think that it's a problem. I mean, we've talked about a lot of the issues that our healthcare system has. It is a problem that I can see a patient who has something like post-viral illness or ehlers-danlos, where I'm concerned about their heart rate, and I send them to cardiology, and cardiology gives them a Holter monitor, and it says normal rhythm of their heart rate. But at rest, it ranges between 50 and 150 at rest. So the kid has no anatomical problems with their heart. And the doctor says, go ahead with exercise. And I'm like, but you saw the 150 at rest, right? Like, something doesn't feel right about this to me. And I hear you saying that their heart isn't damaged, but what about like how they feel in their brain when their heart is doing that? Because they don't get a subjective piece along with it. They get a mailed back Holter monitor with a printout that says normal, and they're like, go ahead. And I think that's just the way our system is set up. It's not, they're wonderful people. These doctors are so great. And when I respond back with, I'm going to do exercise, but like, can we talk about this more? And do you really see this all the time? Like, there can't be. My heart rate doesn't go to 150 at rest.
Yeah, I have to do some serious exercise to get that thing up to 150. Yeah, no, I agree. It's just that, and it's a systemic thing. I agree with you. I mean, no physician's out there to not listen. They purposely, I'm not going to be listening to patients. I mean, I hope not, at least. They're very good people, have all the good intentions, but we have a system where it is so like objective, check the box, and just the ability for a physician to have time to like sit in front of somebody and really, how's this been going for you? When you're dealing with these cardiac issues, how does it make you feel? This must be very frustrating for you. I can't imagine how much stress this has put on you and your family. I know there's some unique docs who find a way, but it's a tough situation.
It puts the PTs, though, in a really interesting possible place. Like, I benefit from this situation because we are not able to segmentalize that way with this patient population. Like, you might be able to, and I don't think we should, but you might be able to with somebody who like had ACL surgery, like forget that they have 3 other extremities, a heart and a brain. But like, what about their cardio? Like, we've seen a really good posts on social media from people who are focusing on specializing in ACL rehab, where it's like, here's why you should go to somebody who only does this. And as somebody who rehabs post-op ACLs, I like the acute phase where they're afraid to walk, they're not walking yet. And I'm capable of doing late stage and doing dynamometry and testing and hop tests and jumping. But I get really concerned when I see them at 4 months out and nobody's done any cardio yet. Like, why have we not gotten your heart rate up? We're 4 months into this process. How much is that going to stink 5 more months down the road when you start to go back to sports? Like, we as a profession have a lot of opportunity to get out of the silos that other specialties, I think, are stuck in because their jobs really need them to be. Like, I want the cardiologist to be an expert in cardiology, but I also want them to not forget the rest of the body happening. So it's really hard because I want it both ways and I want to practice both ways too. But I can't be a specialist in ACL rehab and all the musculoskeletal and also spend my time learning about these chronic pain conditions. There's no way. There's too many things to know. So
yeah, it is an insurmountable mountain of research and things to learn, especially with chronic pain. And conditions that we didn't even really consider in the clinic, a decade ago or so now are like commonplace and how do we best treat these folks and and I agree. I think we're in a unique spot. I think that I love our unique position too, where we can have that discussion about the forest and how you're seeing a bunch and how dysregulation. I mean, I use a lot of stories about how your body in a haunted house versus the beach and, and sunset and how your autonomic system behaves differently. And then when you go through your journey, where do you think, your body's hanging out at the haunted house? And so just helping people key into like, hey, this frustrating, distressing, life altering, flip my life upside down thing is probably going to impact my ecosystem, my forest, and in turn, my GI, my cardiology, all these different things, so people can see that it's all kind of part of the picture. What are your thoughts on lifestyle medicine as far as where does that fit in your practice, and where do you see that with, kids can be challenging with lifestyle as far as, maybe some of the, I know we've had kids where, caffeinated drinks are, and some of the monsters and all these things that don't really help matters when it's coming for some of the stimulants. But what's been your experience, and where does that fit for you?
I actually really love this question. So I think lifestyle medicine might have multiple definitions, but like every single new patient that I see for an evaluation, regardless of what they're coming in for, I'm going to ask them. And remember, I'm in pediatrics, so I don't say, do you eat fruits and vegetables? Because yes or no answers don't get me enough information. I say, what are your favorite fruits and vegetables? And if they can't come up with one of each, usually I worry that they're not having any. And there's no judgment here. They're just, what are your favorites? And because they also connect easily, these aren't scary questions. So it's really good for that therapeutic alliance to start with. So what are your favorite fruits or vegetables? What do you like to drink when you have a meal? And I'm looking for water because I want them to be hydrating, but I'm not going to judge when they do tell me that they drink Mountain Dew, as long as they're also drinking water. So I start with my hydration and nutrition, and then we go to sleep. And I say, how do you sleep at night? What time do you go to bed? Are there other people in the room? A lot of them share rooms with siblings. It's just to get an idea of like, if we need to give attention to this part of your lifestyle, what things can we change and what can we not? But also I've had teenagers who tell me that they're co-sleeping with a parent because the parent has cancer. And it's like, you're afraid you're going to lose your parent. Like I'm going to tell you that it's better for your parent and for you, for everyone to get better sleep that maybe we do like bedtime story in your own bed and then they leave. Like we work on strategies because if they're not sleeping, everything is worse. So yeah, I do hydration, nutrition, sleep. I ask everyone, how's your mental health today? Which I don't know why this is stigmatized. How's your ankle sprain? How's your mental health today? Same question. And then I might ask something else about lifestyle, like what's your physical activity like? Unless they're an athlete who already told me all their sports. That's my lifestyle medicine. It only takes me about 5 minutes to do. And a lot of the time it's interesting because the parent will be like, I didn't know you liked carrots. We don't really buy them that often, but I can buy you more. Like I've had a lot of those and it kind of cracks me up.
Yeah, I've definitely had similar where you're having discussions with kiddos and my mom and dad are like, really? It's interesting how sometimes parents are a little bit bamboozled by some of the answers and different things that their kids say. Tough situation to be a parent in those, when you got your kid. I can't imagine if my daughter was dealing with some of the challenging things that some of our patients are dealing with. So it just really,
Yeah, I mean, as a non-parent, I'm sure that I might come across interestingly to some parents because I think that I would do it in a certain way and maybe they don't. But it's hard to know what you would actually do when you're not raising a child. I mean, I have a niece and nephew who I've watched grow up since they were born and who I would care about as if they were my own children. But I don't know that I would have raised them the same even as my sister, just because we have different, perspectives on everything. So for sure, I think lifestyle medicine matters potentially more than we give it credit for. But I even had a Twitter thread maybe a week ago where a patient had come in. I saw her like a month and a half ago. She was having leg pain, like calf pain, bilateral. And she was having it every single night. And then the school year ends and she travels with her family. So I'd seen her before she traveled and I gave her a home exercise program. And I wouldn't say she was very strong, but she was strong enough for like her activities. I couldn't reproduce the symptom. She goes away with her family and she's gone for 6 weeks, has zero pain the entire time she's gone, comes back, school starts, pain is right back where it was before. And she tells me she doesn't eat at all before school or during school. She only eats after school. And I'm like, I don't know if this is the problem because pain is multifactorial, as we know, but I'm like, I am going to say that we need to get some nutrition on board and like back to the pediatric because it was gone. So whatever made it gone isn't a PT thing. I can give you 1,000 heel raises. I don't think your pain's going to go away.
That's interesting you bring that up. I've had this discussion with colleagues as well about when folks go on vacation or do something where they escape the context of their four walls. I mean, obviously they escape the context of and maybe they were eating well and sleeping well and doing all the things on vacation. And then school starts, like you said, and nutrition goes away and all these different things. I also just sometimes wonder how much we're driven contextually of like, I'm back to my life where this is where all the things that weigh on me, all my distress lies and all these four walls of all the challenges that I lie where, a vacation, Disneyland, whatever it may be, is a break. And I try to bring that into the room of like, what's different on vacation.
Yeah. They also said it was a lot hotter just in general, like wherever they were was hot. And so when they come back a week later and they're like, look, I ate breakfast every single day for the last week because you told me I had to. My pain is still here. And I'm like, what else is different when you're on vacation? Because I'm happy to keep seeing you. You're a very nice kid. But like, I don't think I'm going to solve this. This doesn't feel PT. But I feel like if you don't ask those questions and you observe that they don't hit the norms in the research of whatever number of heel raises you should have or whatever your hip extension strength should be, like you're just going to keep them in PT doing exercises that potentially aren't going to touch whatever the problem is.
Yeah. Yeah, it's like you're not even asking to uncover what might be the root of it. Because I think sometimes I know I defaulted early in my career to what I felt comfortable with. I had my own exercise tree that I clung to tightly, and that was the language I could speak with people because but obviously we know that there's this expansive force of a lot of things that go on with these folks, as you've already talked to, of a lot of the different systems that are impacted, a lot of the, things I like, your questioning of mental health. I always joke with patients. I was like, every you get a physical, I think every you need to be getting a mental as well. I think I definitely am a firm believer and user of mental health as well, where I just think it's just helpful to have that and addressing that. And you just see folks when you start unpacking some of those discussions of anxiety or depression and things.
Yeah, you've had Rachel Zoffness on here. You can't separate mental health from physical health. If she's shouting it from the rooftops for a reason. Like, we need to keep amplifying the message, because I think you asked earlier about like the ACEs, like the early childhood trauma. And I don't feel like I see that necessarily a lot with the kids who are having long COVID or chronic fatigue necessarily. I do certainly see kids who've had traumas, whether that's the reason they're in PT or it's just impacting them. But I have been surprised as I've gone through my life and the experiences I've had of how much mental health can really impact the way your body feels. Like, I mean, I've talked about on Twitter plenty as well about grief and how grief comes out as pain in ways that that bring you to your knees. And I don't think we talk about some of these things nearly enough in PT education for the way that they come across in the clinic.
Yeah, I see students, and I definitely was one of these students as well when I was coming up through PT school, when like emotions hit the room and when things beyond like what I was PowerPointed on, it was uncomfortable, and I would just like abort mission and like, let me just talk about what I know and kind of, I guess, invalidate it because I just didn't know how to address it. And now I think, like you said, like you got to have the ability to just have discussions and have conversations to where you just at least maybe open a door for somebody to kind of identify that, hey, maybe there's more to this than just, how lax my shoulder joint is. Obviously that can be a part of it. Not to say we just disregard that as well, but it's all of the things like Rachel talks about it. You can't separate the two. Yet sometimes as physios, I think we just have this default sometimes, and I know I did, of just wanting to be a physical therapist when people aren't just physical. Their physical is so integrated with the mental and the psychological and all these different things. So I'd love to talk a little bit about your thoughts on POTS, because I know you've been doing a lot of reading on it, and it's one, honestly, I'm a little bit looking to pick your brain to help my practice out as well. I know you've probably read things that I haven't read in different things, but what's been your experience with, kind of your approach and what you see? I know it's a variety and there's no one patient's the same, but what are maybe some common things you see in the clinic and maybe some common approaches you found can help some of these folks, start moving in a better direction?
Yeah. POTS also way more frequent with the females than with the males. And I think we're seeing potentially a spike around the time when they're hitting puberty. So I think that probably a lot of PTs who aren't in the pelvic floor realm forget to ask questions about this. But I think we need to be asking about it if we're seeing patients who have dysautonomia, as well as stress fracture type things. Like, we need to be asking about energy availability, because we know there's a cluster, formerly the female athlete triad, now red S. Like, I think that that's a consideration. So specific to POTS, though, definitely more girls, teenage, not young kids. They're all like the older teens. Like, I probably haven't seen even any that are really under like 15. So like, they've been menstruating for maybe 1 or 2 years, and then they start having it, or they've had a viral illness, because it often comes with illness. The literature talks about like different ways you can have POTS come on, which could be like deconditioning or immobilization following any sort of illness or even surgeries. So like patients who've just been in bed for a long time. We had one patient who had that type of symptom presentation after they were hospitalized with cancer treatments, where like they were in bed doing chemo radiation, and then they were discharged home and like really just couldn't get back to activity because of the dysautonomia. But that was deconditioning, and they're so different in presentation. And over time, we were able to get them back to it. So it's interesting too, because some of the kids with POTS, they get better, and some of them just have to learn how to chronically manage it. And I think that maybe is both things overlapping. So for sure, I've posted several times question of whether or not it's in our scope of practice to like recommend hydration and electrolyte supplementation. Like I take electrolytes myself every single day because I stand at work for 10 hours. And if I don't, I am myself dizzy by the end of the day just because of gravity. And I made that change like 5 years ago, and it was a game changer for my energy and my tolerance to the day. And so now it's like, hey kids, are you drinking electrolytes? And when we do, and we have Gatorade in the clinic, so anyone who gets lightheaded and dizzy, I'm like, drink. And then when they feel better, it's kind of in the moment telling of, oh, actually this has an impact. So for sure, we start with hydration, which usually they've been told by whoever diagnosed them with POTS. Sometimes we're doing compression wear, which our occupational therapists can do, like fittings for compression garments. It kind of depends on how they're presenting. You don't always see like pooling in the legs or even color changes, but some kids with POTS there's a name for it, but I can't remember it, like where their feet are blue. And it's like, it kind of looks almost like CRPS in that there's definite color change, but it's like bilateral and it's in their feet, or it's kind of like a Raynaud's in the hands, but there's this change that's happening. So compression helps for some of them, and those aren't PT things. And then we add in our PT things, like I like to do resisted plantar flexion, however they can tolerate it. So if that's just active ankle pumps and they're not using resistance, that's fine. If it's a TheraBand, that's fine. If it's seated ankle pumps, that's fine. And if it's standing calf raises, it's fine. But everyone's getting one variation to just use that calf muscle pump. And then the level of exercise that we do depends on what they can tolerate. So if they can only really tolerate laying down exercises, we start with that and breathing strategies to try to calm the system down. But if they can tolerate seated, I want to do the most that they're able to tolerate where they're not feeling terrible, because they feel terrible if you really just push them through it.
Yeah. We had spoke about it. It's just, it's the same kind of exercise progressions thought process. It's just, you got to bring it way back. Like you said, some of these folks could even try to sit upright to do exercise. That is just way, way too much for them. And you have to really bring it down to mat-based exercises. And like you say, it could be as much as ankle pumps, maybe get some bands involved, the venous pooling things. It's interesting.
Yeah. And I definitely try to reduce the amount of like head up and down positioning. So, like that could even be a squat or a sit to stand. Your head is moving up and down in space. It's interesting because because they're kids, sometimes they do things and you don't realize that this might be related, but like these kids lay on the floor. Like if you tell them that they can take a break, they don't want to sit on a treatment table or even in a chair. They want to sit or lay on the floor. And it's something about just like gravitational pressures and like feeling better. The number of kids who laid on the floor in the clinic, at first I was just like, this is so weird. And then finally someone was like, my head feels better down here than anywhere else. And they want to sleep on the floor at home. Like one of them told me they were crawling because if they got up, they were just so miserable. But crawling, they could get around and do a lot more of their day. They would like lay on the floor to do their homework, to do schoolwork. They would crawl to the table and like they'd sit up to eat because the family said you need to sit up to eat, but then they'd like crawl back to their bed. And I was just like, this is fascinating. And how do we help you so that you can stop crawling?
Yeah, no, it is fascinating how you just start seeing these clinical patterns form of like, you see enough of a diagnosis, you start seeing these behaviors start to line up of like, man, I haven't seen enough probably to, but I definitely have had some folks who are laying and not maybe on the floor. Our clinic maybe isn't as ideal for that, but
I don't think mine's ideal for it, but when they do it, I'm just like, no, most kids don't do that.
Yeah, it's not a common behavior for sure. Yeah, no, it's a massively challenging situation, and that a lot of these kiddos and families are going through. What has been your experience with the family? Like, how have you found like there's the studies. Adrian Lowe's been the one who kind of kicked them in front of me of like how mom and dad really are reacting to conditions really has a big effect, even like a year down the road of like a kid's pain score. There's the parents' psychosocial stress anxiety scores like 24 to 48 hours after a thoracic procedure. I think it was in one study predicted this kid's pain scores a year out from a procedure. So What has been your strategy with dealing with that dynamic?
My strategy is to start with observing how they interact with each other, because usually the parents all come for the initial evaluation. And our clinic policy is that if the kid is over 10, the parent doesn't have to be present for the session. But under 10, usually they don't have to be there, but they're invited to be there. And so when I feel like the parent is getting in the way, I'm not afraid to say, hey, why don't you wait in the lobby so that we can tell you what we did afterwards? And that's my usual like get out. But I've also, because a lot of them are teens, specifically with these conditions, I've asked the patient directly, hey, are you ready to do this without your parent present yet? Because sometimes they're not ready to do it. They're fearful that they've had near syncopal episodes or even true syncope. So I think they're fearful. And early on, I'm not about to put them in situations where that's going to happen, but you don't always know. And so if they don't trust me yet, they want their parent there. But once we build up the therapeutic alliance, usually they're like, okay, what are you going to do if this happens? And I'm like, well, hopefully I catch you so you don't fall, and then I'll go get them. So we have to have those conversations, but I do think that half of the time parents, and all of it comes from a positive, loving, caring place of like, does it hurt? Does it hurt? Does it hurt? Does that make you scared? Does that worry you? And I'm like, you have to stop asking these questions. Like, we need to get the focus a little bit away so that instead of them hearing what you're feeling, they can listen to their body. And I think once you explain it in that way, the parents are a little bit more ready to be like, oh, they're 17. They should be able to like at least feel if they're a little fuzzy in their head because usually these syncopal episodes they like stand up and they immediately fall back down. It's usually like I start doing something, I ramp up a little bit, and then it's like, oh, nope, can't do any more. So they need to be able to pay attention to the signals, especially if they don't want to wear a watch that tells them their heart rate, or if they're not so in tune to it at the beginning.
Yeah. And when you're trying to teach breathing and relaxation strategies and things, and you got mom or dad, in the room for good reasons, like you said, I mean, it's all in love and it's all in care, but sometimes can spike the anxiety, autonomic meter by how they're reacting in the room. And I think having a play, and it sounds like you have some great strategies, of course, with what you just said, but having the ability to kind of be able to be frank and have a discussion, not in a mean way, but, explain to parents how, their reaction is going to, ramp up the system or decrease the system. Doesn't mean you don't care by any means. It just means we need to all modulate our response to it and let them start to get a little control of their body and not have external factors that are wanting to spike the accelerator again by, somebody in their periphery, doing, and again, I always say, this is all motivating good things. I mean, you care about your son or daughter. It's great. It's just, we just need to make sure we're strategic in how we react and how we let the kiddo kind of navigate some of this stuff and try to learn some ways, like you said, to get in tune with their body and not have some of these things that might deter.
Yeah. My coworkers tell me this is when my East Coast is coming out, because it's not the same personality as some of them would have, where some of them would just kind of are like, it'll be fine. And they just like kind of let it be on the side. And I'm like, no, this is getting in the way. But also sometimes we have to do the other way of like, hey, I need you to support your child in this way, where they're trying so hard to let their kid be independent that the kid feels they don't have enough support. I also think that comes from a place of love, of you wanting your 17-year-old to be working towards being an adult. So you don't want to be overbearing, but at the same time, your kid is really struggling. So here are ways that we can, put you into the mix so that they feel supported without crossing all of the boundaries.
Yeah, that would be something I'd have to be careful of. My wife always gets annoyed with me of like, whenever my daughter experiences anything, it's like, she needs to navigate this. She needs to figure it out. We don't want to get her freaked out about every scrape and bump she experiences in the world, because there are going to be plenty to follow. And I think it's great you brought that up, as far as like, sometimes, you got to figure out there's a balance. Sometimes it's too much, distressing interaction, and maybe sometimes not enough support where the person feels like they have that one little somebody to help shoulder some of the load of maybe what they're dealing with, which obviously can be very challenging. Abby, I want to respect your time. I've really enjoyed the conversation immensely. I would love to hear. I know you're going to be doing some talks coming up. I'd love to hear what you're up to and what you got going on.
Yeah, I'm excited to start getting invited to speak in a few places. This is new for me, so I'm looking forward to it. I'm going to do a talk at UConn Physical Therapy for, they have a course that they wanted to do a talk, sports physical therapy in the clinic versus on the sidelines, which I've given that talk once before to University of St. Augustine, so we'll revamp that. And then also I'm going to do a talk about POTS and chronic fatigue at Hartford Hospital while I'm home for Thanksgiving in Connecticut. So little November busyness. And then coming up in February, there's a conference in Minneapolis that is the TRIA conference. They haven't finalized. I think the theme is adolescent rehab this year. So they've asked me to speak and we haven't finalized the topic, but something about adolescent rehab versus adult rehab for potentially a certain condition. And then I'll have my first talk at CSM, which will be CRPS, and that's with Karen Litzy and Deborah Sheldon. So I don't think you've had either one of them on your podcast, but they belong here.
They do belong here. I know both Karen and Deborah. I've met them both. They're great people, and they definitely need to be on the list of folks that we're chatting with for sure. For sure. No, I'm looking. I won't be in CSM this year. I'm going to be on a cruise because it's our 10th anniversary. So I got to. And it's in Boston. I mean, I love the Northeast. Don't get me wrong. I'm not a hater on the East Coast, but I do like Southern East Coast a little bit more.
Sure. Who wants to go to Boston in February? This was not my choice, but it is home. Connecticut's home, so I'll look forward to getting to see my family while I'm in the same trip.
Well, awesome. I mean, obviously, you're doing great things, and people are recognizing you're getting asked to talk and share your expertise. Where can folks? It sounds like X is the spot where you do a lot of your ponderings of things, and is that primarily where folks can kind of get in touch with you or see your content?
Sure, yeah, I'm on there. I'm on Facebook, Twitter, Instagram, email. Find a way. I'm responsive to everything. LinkedIn. People message me on LinkedIn a lot, more than I would have guessed. I think it's probably because they search for like WNBA stuff. So yeah. Wherever I'm communicative.
Yes, you come across very well. You're well spoken, and you can tell that folks that are under your care are lucky to have you as their PT. And I really appreciate your time tonight, and thanks for all the good stuff you're doing.
Thanks for having me.
All right. Well, we're going to wrap it up with that. For those of you who aren't subscribed to the podcast, you need to get on your podcast vendor and subscribe to the podcast so we can get more folks like Abby's voice out there. So people with POTS and EDS and those folks and clinicians who are struggling with that can listen to it. If you're watching it on YouTube, we'd love to hear you or have you subscribe, or maybe even just toss a comment in there. What's your experience with this? What have you found? Share some pearls. Maybe we all can learn. That's what this stuff's all about. So again, thank you for all your time. Thank you for spending some of your precious time and listening to the content we produce. We'll talk to you next week.